Hello everyone. Today I'm going to start the topic again in continuation with the health policy which I had been talking about. Today I'll briefly discuss all the policies starting from 1983, then 2002, and then 2017. What were the health programs which has been initiated, and certain statutory provision as well as certain legislations in the context of health policies and program. Before that, I just want to talk very briefly about Alma-ata Declaration. This was a joint WHO UNICEF international conference which has taken place in 1978, declared that the existing gross inequalities in the status of health of people, particularly between developed and developing countries as well as within the countries, is politically, socially, economically unacceptable. So this Alma-ata Declaration called on all the governments to formulate policies, national health policies in every country according to their own circumstances, according to their own situations, resources, according to their own needs and expectations, to sustain and to launch primary health care as a part of national health system. The Alma-ata Declaration of 1978 also emerged as a major milestone of the 20th century in the field of public health, and it identified primary health care as a prime or at least the key attainment of the goal of health for all around the globe. So this Alma-ata conference called for the acceptance of the WHO goal of health for all by 2000 AD, and primary health care as a way to achieve health for all theme. This Alma-ata Declaration, they defined that primary health care is an essential health care based on practical, scientifically sound and socially acceptable methods and technology, made universally acceptable to individuals and families in the community through their full participation and at a cost that the community and the country can afford. So based on this Alma-ata Declaration and various initiatives, even in the 5-year plans, health had been certain allocations had been done, and certain robust system had to be developed in terms of healthcare in service delivery to the larger population. However, there had been certain lacunas in the delivery system, and there was a huge disparities among the rural and urban healthcare system also. Nevertheless, after the Alma-ata Declaration also, and since there was this urge to make health policies all around the globe, which would ensure health for all under the line of the previous in 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 sync with the previous healthcare initiatives, and particularly in India, and how the 5-year plans also advocated about or also assigned certain provisions for health benefits in India. The health policy of 1983 came in existence during the 6th plan, and this national health policy, in the light of the directive principles of the state policy of the Constitution of India, recommends universal, comprehensive primary health care services which are relevant to the actual needs and priorities of the community, and a cost which people can afford. Providing universal health care has been a goal, and it is a welcome step, because this is for the first time after the Bhore Committee that the government is taking care of universal comprehensive healthcare system. So health policy is thus becomes the expression of what the healthcare system should be, so that it can meet the health care needs of the people. As a consequence of the global debate on alternative strategies during the 70s, the signing of the Alma-ata Declaration on primary health and the recommendation of the ICMR ISSR joint panel, the government decided that the above fora may have served the needs in the past, but a new approach was now required, and thus this health policy came into existence of 1983. So it felt that an integrated, comprehensive approach towards the future development of medical education, research, as well as health services requires to be established to serve the actual health needs and priorities of the country. So that's why this health policy were evolved, and they were looking into the various aspects of health measures. The objectives of health policy of 1983, there were certain important objectives. First of all, a phased time-bound program was setting up of a well-dispersed network of comprehensive primary healthcare services linked with extension and health education, designed in the context of the ground reality that elementary health problems can be resolved by the people themselves. Secondly, intermediation through health volunteers having appropriate knowledge, simple skills and requisite technologies. Then establishment of a well worked out referral system to ensure that patient load at the higher levels of the hierarchy is not needlessly burdened by those who can be treated at the decentralized level. And then integrated network of evenly spread specialty and super specialty services, encouragement of such facilities through private investments for patients who can pay, so that the draw of the government's facilities is limited to those entitled to free use. Then there are few questions apart from the objectives. Three important questions were taken up. The first, the task enlisted in the 83 has been fulfilled or desired, has yet been has been fulfilled or not. Secondly, were these tasks and the action that ensued adequate enough to meet the needs, basic goals of the 1983 health policy by providing universal, comprehensive primary healthcare services relevant to actual needs and the priorities of the community. And thirdly, did the 1983 National Health Policy sufficiently reflected the ground realities in healthcare provision? So these important questions were need to asked during the 1983 health policy, and these were the salient features. The important feature or the important key components of this health policy was, first of all, it was critical of the curative, preventive oriented Western model of healthcare. It emphasized a preventive, promotive and rehabilitative primary healthcare approach. It recommended a decentralized system of healthcare, the key feature of which were low cost deprofessionalization, that is use of volunteers and paramedics and community participation. It also called for an expansion of the private curative sector, which would help reduce the government's burden. It recommended the establishment of a nation network of epidemiological stations that would facilitate the integration of various health interventions, and it set up targets for achievement that were primarily demographic in nature. So, during the decade following the 1983 National Health Policy, rural health care received special attention, and a massive program of expansion of primary health facilities was undertaken in the 6th and 7th plans to achieve the target of 1 PHC per 30,000 population and 1 subcenter per 5,000 population. So, this target has more or less been achieved, though few states still lag behind. However, various studies had been taken up to look into the rural primary health care, and observed that though the infrastructure is in place in most areas, they are grossly underutilized because of poor facilities, inadequate supplies, insufficient effective personnel, poor managerial skills of doctors, faulty planning of the mix of health programs, and lack of proper monitoring and evaluatory mechanisms. Further, the system, being based on health team concept, failed to work because of the mismatch of training and the work allocated to health workers, inadequate transportation facilities, sometimes non-availability of appropriate accommodations for the health team, and unbalanced distribution of work time for various activities. So, the development of healthcare services post national health policy provide a clear evidence that privatization and private sector expansion in healthcare has occurred rapidly because of these various inadequacies, because the model of the primary health care being implemented in the rural areas has not been acceptable to the people, as evidenced by their healthcare seeking behavior. So, the rural population continues to use private care, and whenever they use public facilities of primary care, it is the urban hospital they prefer, and that in the name of primary healthcare, the state has still kept the periphery without adequate curative services. Thus, it was felt the need that this needs to be tackled immediately. This above analysis indicate that the 1983 national health policy did not reflect the ground realities adequately, and the task enunciated in the policy were not sufficient to meet the demands of the masses, especially those residing in the rural areas. So, universal comprehensive healthcare services and the 1983 NHP goal is far from being achieved. So, the present paradigm of healthcare development has in fact raised inequities, and in the current scenario of structural adjustment, the present strategy is only making was only making things worse. So, the current policy of selective healthcare and a selected target population has got even more focused since 1993 World Development Report investing in health. Then on the line, since there were certain inadequacies in 1983 health policies, and there were a lot of deliberations and discussions were done in order to look into how these could be rectified and what other changes could be made and how it can be further modified. So after a lot of deliberations and discussions, the draft bill and again another policy in extension to the previous policies with making certain changes, the National Health Policy of 2002 came into existence. So this was a revised health policy for achieving better health care, and unmet goals has been brought out by the government of India. That was this policy of 2002. So according to this revised policy, government and health professionals are obligated to render good care to the society, organizing the use of health services to a larger group rather than a small group is foreseen event by the NHP of 2002, and inclusion of social policies to the credit of the revised NHP 2002. So the main objective of national health policy, it could be said, that was to achieve an acceptable standard of good health amongst the general population of the country, and the approach has been to increase access to the decentralized public health system by establishing new infrastructure in deficient areas and by upgrading the infrastructure in the existing institutions. These were the important goals of national health policy, and which was to eradicate polio and yaws by 2005, eliminating leprosy by 2005, eliminating Kala Azar by 2010, eliminating lymphatic filariasis by 2015, active zero level growth of HIV AIDS by 2007, reducing mortality by 50% on account of tuberculosis, malaria, other vector and waterborne diseases by 2010, reduced prevalence of blindness by to 0.5% in 2010, and reduce of IMRs to 30 per 100 per thousand and MMR to 100 per lakh 2010, and increased utilization of public health facilities from current level of 75%, which was the year in 2010. These were the certain areas by which year it has to be achieved. Then establishing an integrated system of surveillance, national health accounts and health statistics by 2007, increased health expenditure by the government as a percentage of GDP from existing from 0 to 9% to 2.0% by 2010, and increased share of central grants to constitute at least 25% of total health spending by 2010, and finally increased state sector in health spending from 5.5% to 7% of the budget by 2005, and further increase of state sector health spending from 7% to 8% by 2010. So these were the certain important goals of 2002 which were in place, which had to be taken into consideration. These were the important objectives of NHP of 2002. First, primary healthcare approach, a decentralized public health system, convergence of all health programs under single field umbrella, strengthening and extending public health services, enhanced contribution of private and NGO sector in healthcare delivery, and increase in public spending for healthcare. The National Health Policy of 2002, gives the primary importance to ensure a more equitable access to health services across the social and geographical expanse of the country. Emphasis has been given to increase the aggregate public health through a substantially increased contribution by the central government. Priority would be given to preventive and curative initiatives at the primary health level through increased sectoral share of allocation. And the main highlights of the policy were that increased health sector expenditure to 6% of GDP, with 2% of GDP being contributed as public health investment by the year 2010. With the stepping up of the public health investment, the central government's contribution would rise to 25% from the existing 15% by 2010, and increased allocation of 55% of the total public health investment of the primary health sector, and the secondary and tertiary health sectors being targeted for 35% and 10% respectively. The gradual convergence, second important part was the gradual convergence of all health programs under a single field administration, vertical programs for control of major diseases like TB, malaria, HIV, AIDS, and also the reproductive and child health and universal immunization program would need to be continued till moderate levels of prevalences are reached. Program implementation to be effected through autonomous bodies at state and district level. The interventions of the state health departments may be limited, but nevertheless the presence of the state government officials, social activists, private health professionals, MLA MPs, on the management boards, on the autonomous bodies will facilitate well-informed decision making, and all rural health staff should be available for the entire gamut of public health activities at the decentralized level, irrespective of whether these activities relate to national program or public health initiatives or not. And in fact, the NHP 2002 recognizes that to implement such changes, not only would the public health administrators be required to change their mindset, but the rural staff would need to be trained and reoriented. The third important part was that the policy envisages kick-starting the revival of primary health system by providing some essential drugs under the central government funding through the decentralized health systems, recognizing the practical need for levying reasonable user charges for certain secondary and tertiary public health care services for those who can afford to pay. The next point was the state government would consider the need for expanding the pool of medical practitioners to include a cadre of licentiates of medical practitioners, medical practice, and also the practitioners of medicine and homeopathy. Such practitioners, even outside their disciplines, can provide simple services and procedures. Then the scope of use of paramedical manpower of allopathic disciplines in a prescribed function area adjunct to their current functions would also be examined for meeting simple public health requirements. And next was enforcing a mandatory 2-year rural posting before the awarding of graduate degrees. This would not only make trained medical manpower available in the unserved areas, but would offer viable valuable clinical experience to the graduating doctors. The policy envisages the setting up of medical grants commission for funding new government medical and dental colleges in different parts of the country. This move was taken up in order to ensure, or in order to enable the fresh graduates to contribute significantly, effectively to the providing primary health services as the physician of first contact. This policy identifies a significant need to modify the existing curriculum, a need-based, skill-oriented syllabus with a more significant component of practical training would make fresh doctors useful immediately after graduation. And this policy also recommended a periodic skill updating of working health professionals through a system of continuing medical education. And the policy also envisages that the creation of additional seats for postgraduate courses should reflect the need for more manpower in the deficient specialities. And it also talked about, or rather this policy also envisaged the aggressive implementation of mandatory norms to raise the proportion of postgraduate seats in these disciplines in medical training institutions to reach a stage wherein 1/4 of the seats are earmarked for the public health family medicine. Then panchayat bodies were to be involved more in healthcare programs, and all the state governments to consider decentralizing the implementation of the programs to such institutions by 2005. The policy also emphasized the need for an improvement in the ratio of nurses vis-a-vis doctors as well as beds, and the policy emphasizes the need of basing treatment regimes in both the public and private domain on a limited number of essential drugs of a generic nature. So, to encourage the use of only essential drugs in the private sector, the imposition of fiscal disincentive would be restored to, and the production as well as the sale of irrational combinations of drugs would be prohibited through the drug standard statute. Not less than 50% of the requirement of vaccine sera would be sourced from public sector institutions so that the country is not dependent on imports. The next was the setting up of an organized urban primary health care structure is contemplated with two tiered one. The primary center is at the first tier covering a population of 1 lakh, and a second tier of the urban health organization at the level of government general hospitals, and the funding for the urban primary health system would be jointly borne by the local self-government institutions and the state and central government. Then there was the establishment of a fully equipped hub-spoke trauma care networks in large urban agglomerations to reduce accident mortality. Then the upgrading of the physical infrastructure of mental hospitals, institutions at central government expense so as to secure the human rights of this vulnerable segment of society. Then, in view of the overdependence of mass media, the policy proposes to focus on the interpersonal communication of information and on folk and other traditional media to bring about behavioral change. The program will also have the component of an annual evaluation of the performance of the non-governmental agencies to monitor the impact of the programs on the targeted groups. Then it was taken into consideration to give priority to school health programs which aim at preventive health education, providing regular health checkups and promotion of health-seeking behavior among children. It would be the most cost-effective intervention as it improves the level of awareness not only of the extended family but the future generations as well. An increase in government-funded health research to a level of 1% to the total health spending by the 2005, and thereafter up to 2% by 2010. Then research programs taken up by the governments in drug vaccine development would be conducted in a mission mode. Time-bound applied research for developing operational applications would be undertaken. Regulating minimum infrastructure and quality standards in clinical establishment, medical institutions by 2003. Guidelines for the conduct of clinical practice and delivery of medical services are targeted to be delivered over the same period, and the policy envisages graduation to a scheme of quality accreditation of clinical establishments, medical institutions for the information of citizenry. Then the setting up of another important part was the setting up of private insurance instruments for increasing the scope of the coverage of secondary and tertiary sector under private health insurance packages is being considered. A social health insurance scheme funded by the government and with service delivery through the private sector would also be considered. As a first step, the policy also envisages the introduction of a pilot scheme in a limited number of representative districts to determine the administrative features of such an arrangement as to the requirement of resources for it. Next important part was the involvement of non-governmental practitioners in the National Disease Control Program so as to ensure that standard treatment protocols are followed in the day-to-day practice. Then significant contributions made by NGOs and other institutions of civil society in making health available facilities, services to the community. The disease control program would earmark not less than 10% of the the budget in respect of identified program components to be exclusively implemented through these institutions. The state would encourage the handing of public health outlets to any of the for the management by NGOs and institutions of civil society. Then full operationalization of an integrated disease control network for the lowest rung of public health administration to the central government with 2005. And the program also asked for setting up the network which will include components relating to the installation of database, handling hardware, and so on. Then baseline estimates for the incidence of the common diseases like TB, malaria, blindness would be done by 2005. Then estimates would also be done for the non-communicable diseases like CVD, cancer, diabetes, and accident injuries, and so on. So NHP of 2002, it envisaged that with accessibility to such reliable data on the incidence of various diseases, the public health system would be much more closer to the objective of evidence-based policy making. Then there was a need to establish national health accounts conforming to the source to users matrix structure, which would help in estimation of the health costs on a continuing basis. Improved and comprehensive information through national health accounts and accounting system would pave the way for decision makers to focus on relative priorities, keeping in view the limited financial resources sector in the health sector. Then the highest priority of the central government funding of the identified programs related to women health. Then there was again a comprehensive code of ethics which has to be notified and rigorously implemented by the Medical Council of India. Establishment of statutory professional councils for paramedic disciplines to register practitioners, maintain standards of training and monitor performance. Then the standards of food items will be rigorously and progressively tightened up at pace, which will permit domestic food handling manufacturing facilities to undertake necessary upgradation of technology so that they are not shut out of this production sector. And ultimately food standards will be close if not equivalent. The specifications and the drug standards will also be at par with the most rigorous ones adopted. Then the periodic screening of the health conditions of the workers, particularly of high risk health disorders associated with their occupation, has to be taken into consideration. Then the providing of such health services on a payment basis to service seekers from overseas like medical tourism, payment in foreign exchange, all fiscal incentives, including the status of deemed exports which are available to other exports of goods and services would be extended. And lastly, a national portal regime for the future, which while being consistent with the TRIPS, avails of all opportunities to secure for the country under its patent laws affordable access to the latest medical and other therapeutic discoveries. Now, National Health Policy of 2017, these were certain important part of national, after the policy of 2002 and after the gap of almost 14 years, the National Health Policy 2017 came into existence, and the National Health Policy of 2017 came after 14 years gap, and therefore the content or the context of health changed in many ways. The growing number of non-communicable diseases and infectious diseases, rise of private sector, increased expenditure on health, and rising economic growth enabled enhanced fiscal capacity, having shaped the 2017 policy. In fact, the policy aimed at providing healthcare in an assured manner to all. There has been a shift from sick care to wellness and well-being of the individuals, and the Make in India model governs the manufacturing of drugs and devices. Ayush is given special emphasis, especially yoga. The NHP of 2017, the National Health Policy of 2017, identifies 7 priority areas for improving the environment for health, and these priority areas needed coordinated action, which like the Swachh Bharat Abhiyan, balanced healthy diets and regular exercises, addressing tobacco, alcohol and substance abuse, then Yatri Suraksha, preventing deaths due to rail and road traffic accidents, then Nirbhaya Nari, action against gender violence, and then reduce stress and improve facility safety in the workplace, and reducing indoor and outdoor air pollution. I will stop my lecture here today, and I will continue talking about National Health Policy 2017 in little bit more detail, as well as the constitutional provisions and legislations in the area of health in my next lecture. Thank you.